happy to share that we have Dr. Mike Scharf in today to talk about treatment for teens with significant mental health concerns. And Mike, do we have you on the line?
Yes, I'm here. 15 years older and more than that many pounds heavier than in the picture on your screen.
All right, so I just spotlighted you, Mike, so everyone can see you in the corner.
Hello, everybody.
So we're really pleased to have him here. He is our chief of the Division of Child and Adolescent Psychiatry here. And he is also our site leader for Project Teach, which is an OMH-funded program geared at providing education and clinical consultation for primary care for providers as they're caring for the mental health needs of children and teens. I know we've talked about Project Teach here before. And Mike, we're really happy for you to join us to talk about the state of affairs around outpatient care resources, which is a hot topic these days, as well as partial and inpatient and emergency room and mobile crisis and CPEP and all of that. So without further ado, I know that you're having a little bit of trouble with your Zoom. Are you okay to share your screen for today or talk off the cuff?
I'll do either. I'm going to try to share my screen.
Great. Let me stop my share. Yep. And I'll hand it off to you. And we have until about 11:35 for you. And then we're going to move over to our case presentation for today.
Sounds good. Okay, can I just get confirmation that people see the screen and you're seeing just the slide, not the presenter view?
That's right.
Okay, great. All right. Well, let me just find where my clock is on this. Okay, great. Just to start with disclosures, I don't have any conflicts of interest. The disclosure I have to make, which is not a conflict, is that we talk about the mental health system as if it's one thing, but there really isn't a single overarching system. And I think I don't need to do more than point out the updates that we talked about, that not everyone knew everything about what's happened since the last time you met. That really shows that. It would be nice if there was a synthetic single system where we could talk about a point of access that connects one with the right service, but it's not quite that smooth. And some things are actually explicitly siloed, adding another layer of complication. And so we still use the term, right? I use it sometimes, the mental health system, but as a useful shorthand. But it shouldn't be a surprise to anyone when you try to access systems that it's not one system. This is reinforced by how we are licensed and accredited, and at an individual level as well as a clinic level. And there's multiple agencies involved. The Office of Mental Health, probably the most significant for the kinds of things we're going to talk about today. The Department of Health is actually the licensing agency for many things. OPWDD is the Office of Persons with Developmental Disabilities. To make that one more complicated, people in counties and regions sometimes still use the old abbreviation of DDSO. And then we have OASIS, which is regulating and certifying places that focus on substance abuse or substance use disorder services. And then OCFS is the Office for Children and Family Services. The kind of things I'm going to talk about in the next few minutes, that comes into play more for residential options, but it also includes regulation and funding for some reentry and prevention services that we could think of as related to court detention or other legal proceedings or prevention to try to prevent people from getting connected or involved with them. So when we talk about levels of care, this is how I divided it up. And I think this is probably the most useful way to think about it right now in terms of points of access. What I'm going to do today with the slides is show you kind of what we have now and talk about that. And then I'm also going to talk a little bit about what's coming up, because as a sneak preview of that, my comments about there not being a system, about being difficult to figure out how to enter where and not having a single point of access, this is not news, and it's something that a number of folks are trying to address and make improvements in. So I'll speak to that as well. It's really important if you're trying to access services, whether it's for yourself, for your family, or for students that you work with, to be able to communicate. For when we think about this from schools, that could involve FERPA as well as HIPAA, which is about protecting medical confidentiality. The advice I have is to get consents as early in any process as possible. There are a few examples of general consents that you can use. Many facilities want to have their own form utilized, even though it says the same thing as all the others. For actual clinical providers who are caring for a given person at the same time, you don't actually need a consent according to federal regulations. But that does not prevent local groups, schools, clinics, institutions from requiring consents. So it can be challenging to figure out exact details, what's really required, what's just what people think is required or what they want, but it's always best to get consents that communicate as early in a process as possible. And of course, there are still limits to confidentiality. Even if people have a thoughtful discussion, say they don't want you to communicate, if there are safety issues, then you've passed the limit of confidentiality. Safety trumps confidentiality. So when we talk about the first level of care, I describe this as primary care, school or education settings, and then community supports that aren't organized as part of healthcare or clinical intervention. This is what many refer to as the de facto mental health system, because whether it's because of stigma or quantity of services being inadequate, many people who are suffering never get to a mental health provider. And the majority of actual supportive contacts that happen and first line assessments that happen in this level of care, in these worlds: primary care, education, and other community settings. Um, in fact, it's even more significant than that. It's not just the first point of discovering a problem and supports, but the majority of psychoactive medication prescriptions are prescribed by primary care providers. That includes stimulants, antidepressants, and it's more than a third of antipsychotic prescriptions are actually prescribed by primary care. Schools vary widely. I'm sure you guys have already talked about this amongst your own groups, what you can actually provide within the school district or even within a district in a given building. And we're as a community trying to more systematically address what's right sized, if you will, to be in a school setting, and what do we need to do at a community level to say, okay, that's more than we should expect to happen in a school building. But this is to say that that's done, that's figured out forever, simply wouldn't be true. And I think you guys all know that by the fact that you're here. Now, outpatient then being a separate level of care, also we use the term ambulatory, which is, both of these are based in the history of talking about healthcare as being either something that's delivered in the hospital or not in the hospital. We could certainly argue that this is an outdated term and not the most useful one, but nevertheless, that's what we generally use. So outpatient would be any appointment you make at a clinic, an individual private practice. This can include all sorts of interventions: group, family, individual, can include medication and other assessments. And this is where healing really happens. Now, I'm going to escalate, if you will, into higher levels of care, responding to crisis and emergency situations. But when we talk about the delivery of care resulting in changing outcomes, it's actually an outpatient where the healing happens. We find ourselves sometimes, when we think about crises, in these high stakes situations where we want to not only keep everyone safe right now, but expect some intervention to fix everything right now or in a short-term intervention. But the reality is there's very little, almost nothing we deal with when it comes to mental health, behavioral health issues that gets resolved in a single visit or even an inpatient admission. This is where the healing happens. In terms of tips for communicating with outpatient services, the first thing, and maybe the most important thing, is to keep in mind that not all outpatient care is the same. Not all psychotherapy is the same. And you should feel empowered to ask providers what they're providing and how long you would expect to provide this service, whatever it is, before you would see a difference, because that helps guide what you do next. If the child doesn't seem to be any different than last week, that might be what's expected. Or it might mean that it's time to discuss with the team doing something different. So you should feel empowered to ask about that. And while there are certainly some therapies that are evidence-based and others that are not, I would say the state of mental health care in our community and really across the country right now is such that if you can speak to a therapist, a clinician who is confident about the plan they're doing, I'm not sure that it's worth questioning whether they're doing an evidence-based technique or not, but the more you know, the better equipped you are to have those conversations. What is a red flag is if you ask someone what type of care they're doing and they can't really answer you, answer your question. That would be a concern. A clinician should be able to articulate what the care is, what's happening, and how long before you'd expect to see some change. Now, intensive outpatient is a level of care. We don't have intensive outpatients for general mental health in our region. Some areas do, for kids. There is an intensive outpatient program for eating disorders with the Healing Connection. There are occasionally outpatient intensive programs which kind of come and go in our community, but right now it's not of a substantial enough size to talk about it as something to collaborate or seek a referral to. Partial hospital for teenagers, for adolescents. We have the only partial hospital program at U of R on this side of the Hudson. And we've also been the only one continuously in operation for more than a few years at a time, since 1996. It's a well-established program, currently serves up to 33 youth at a time. You get more treatment than in the hospital, but like with outpatient, the language is based on this history of hospital versus not hospital. It's called partial hospital because the idea is historically you get all the care you could get in the hospital, but you go home at the end of the day. And nowadays you actually get more care, more treatment in partial than you do in the hospital. You just don't get the 24/7 nursing supervision. This is still, as intensive as it is, about crisis resolution. People who are referred have a functional or a safety issue, putting them at high risk of either harm or being hospitalized. And the length of stay is typically around 3 weeks, with the idea of getting someone stabilized enough to return to their day-to-day life, school, whatever outpatient therapy is appropriate, and resume their lives. Some of the key issues with partial hospital, as outstanding as I believe it is in terms of delivering intense care, it only works if people show up. So while we are still transitioning from everything closing down during the pandemic, we have both a virtual milieu and live right now, about equal sizes. We are transitioning back to all live again. And the history we have of school districts providing transportation has been really essential to our program staying open and to kids benefiting from it. So if yours is, and for the most part in Monroe County, districts provide transportation when children need it, but occasionally districts are unable to, whether it be because of staffing or they just decide that year that they're going to use resources differently. But if you're ever in a position to advocate for that, I do believe that's really important. And communication is also really important. When someone's in partial hospital, they're out of school. We have Rochester City School District teachers that provide education, try to help people get caught up and return to go back to school if that's been an issue. And I believe, do a pretty good job of communicating the education plans back and forth, but sometimes the communication will be between the educators. And if we want to make sure there's also communication with the clinical team about any recommendations or things that need to happen. This is important enough, and this is a fast enough moving service that if communication with partial is a problem, I actually personally want to hear about it. And so I would encourage you to contact either the director of the program, Charlene Weeks, or you can contact me if communication is a problem with partial hospital. And then inpatient. Now, inpatient, we talk about as one thing, being hospitalized, but there are actually different levels of inpatient care. What we have in our region at U of R is a acute inpatient unit. And so that means it's designed for about a 10 to 14 day length of stay. Right now, I've been saying that our length of stay is 7 to 10 days, and that is literally true in terms of a mean, but it's actually bimodal. We've developed a more intensive program that gets people who are appropriate for it out in 3 days, and about 15% of our admissions fit into that category right now. And for the rest, it's 11 to 14 days. But that's short term. It's even shorter term than partial hospital. So it's appropriate when someone can't be safe at home or can't participate in care outside of the hospital. But it's about addressing safety. It doesn't fix everything. Similarly, communication is essential for people to have a successful discharge plan. And we expect communication of our treatment teams with the schools, but not having outstanding or rich communication can't be a reason to not discharge just because of the nature of care. So again, I want you all to feel empowered when you have a student that you're working with admitted to call, expect to be able to speak to the clinical teams. And despite our best efforts, sometimes people will be discharged before the best communication happens. We're always trying to improve that. The other level of inpatient care, which we don't have locally, the closest is in West Seneca, and there's another in Elmira, is what we call intermediate inpatient care. In New York State, all of these units are regulated and run by the state OMH, Office of Mental Health. And this is intended to be for a 30 to 90 day stay. Almost all, not all, but almost all patients who go to that level of care come through an acute inpatient unit first, so you can be referred directly for this level of care of hospitalization. It's less restrictive than the acute inpatient unit. Kids can go outside, they can have home visits, but it is still mostly on a locked unit and in a secure environment. The communications with school to have discharge planning are even more important because the kid's been separated from their day-to-day life and school plan for an even longer period of time. Residential is what it sounds like. Kids reside there. There are different types of residential regulated by different agencies. It's intended in all cases to be highly structured, therapeutic living experience. These are unlocked units. They're not restrictive in the same way as hospitals. And whatever mental health care is going to happen is included as part of residential care. People don't go to a different clinic or somewhere else when they're in residential. Lots of ways to access residential. If there was a period of time where you had to go through a county SPOA, which is SPOA stands for single point of access, but now you can apply to residentials directly or continue to use SPOA. They all have a goal to return home, and generally speaking with a 9-month term, except for legal placements where it's like a sentence to go to residential.
And Mike, we are about time to wrap up on this portion. Yep. I'm wondering if you could spend the last 30 seconds, there you go, talking about CPEP, MC.
That's what I'm planning. The emergency services, or we could use the term crisis services, is the area where we probably have the biggest challenge right now in terms of level of care meeting people's right now needs. This is not one level of care. There's multiple different approaches. I list them here in the slide. There are crisis phone lines. You can call 911, you can call Lifeline. We've also established a crisis line, 275-8686, which is always staffed by clinicians to help triage and figure out the right thing to do. We have a mobile crisis team, and we've been expanding the size, have plans to expand even further. But as of today, we're only able to actually get up to see 75% of the cases that are triaged as appropriate for mobile crisis, and that's just due to capacity. And then there's CPEP, which stands for Comprehensive Psychiatric Emergency Program. This is a locked facility where when you come in there, you have to stay until the psychiatrist evaluation is complete. Sometimes people's lives are immediately at risk. This is the right thing to do. Um, but it is not for the faint of heart, so to speak. It's probably not a good idea to go to CPEP for anything less than an emergency because it can take so long to be seen, and it's a very chaotic, challenging environment. The looking toward the future, we're planning to open a walk-in crisis center targeting the fall or winter of this coming year to, if all goes as planned, largely replace CPAP as the crisis walk-in center for our region. The the I'm going to end because of time. I can answer questions about that. The other services I mentioned, CPEP will continue to exist, and the mobile crisis will be expanded, and we'll be also trying to expand the size of our outpatient services and collaborate with other providers to get closer to having it feel like a system where you can have a point of access at any of the services and be connected with the right levels of care and the right intervention. I went over by a couple minutes, but I'm pretty close. Sorry if I've derailed anyone else.
No, I think you did a really great job, and it's such a short period of time to talk about so many comprehensive resources. I think this group is particularly excited to hear about some of the developments in emergency services, and also I think it's reassuring for the teams here to hear that we want outreach, especially for partial and inpatient care and collaboration with the school teams, and that also getting releases of information as a standard of practice is just really critical for making sure that we can have that communication and collaboration.
Absolutely.